What's going on, all of my healthcare brothers and sisters? I hope that you are having a wonderful day. We're continuing on with the Vital Signs Assessment series, and we're going to be looking at pulse rate. Let's get started. So to begin our pulse rate assessment, we really need to understand what the normal ranges are for our adult patients. So when it comes to the average adult pulse rate, it's going to be between 60 to 100 beats per minute. That means that sinoatrial node is firing to tell the heart to pump. Now, if you have absolutely no idea what I'm talking about, I highly recommend that you go back and watch my video when it comes to the heart electrical pathways and how that works with the pumping of the heart. Lastly, if you have a patient that has a lower pulse rate, this can actually be normal in a well-conditioned adult. So if you have an adult that's such as like an athlete or they're very athletic, they do like a lot of 10Ks and all those things, they may have lower pulse rates, and that actually may be normal. So I've had patients that had pulse rates in the 50s and they were asymptomatic, and that was normal for them. That's where their heart kind of sat. So you definitely have to use your clinical judgment to determine what is normal and abnormal when it comes to your patient populations. Now, when it comes to the pulse definition, a pulse rate is a palpable bounding of blood flow in the peripheral artery and is an indirect indicator of the circulatory system. So changes in pulse rate can occur during ambulation, dressing, bathing, and exercise. Pedal pulses are evaluated to assess for blockages in circulation. So this can be difficult to locate and may require a Doppler ultrasound stethoscope to amplify that pulse waves so that you can hear if those pulses are present. One important thing to note: if the heart is made up of both electrical pathways and mechanical pathways. So if the electricity goes out, such as our SA node, AV node, bundle of His, left and right bundle branches, as well as those Purkinje fibers, that mechanics of the heart is still going to work. That's your valves. That's the opening and closing of your valves. So those things are still going to work, even though the electricity has gone out. All right, so let's take a look at what the pulse rate assessment procedure looks like. In order to perform this procedure, you need to gather the equipment you need for the examination. So you want to make sure you have your stethoscope, a timer, as well as an index and middle finger. You never want to use your thumb because you've got a pulse here and you might confuse your own pulse for someone else's. So that index finger and that middle finger. So let's look at these pulse points and locations. The most common ones that you're going to use in practice are your carotid, your apical, and your radial pulse, but there are additional pulses that you need to be aware of. So to begin, you have your temporal pulse, and that can be palpated anteriorly to or in front of the ear. So that's your temporal pulse. You have your carotid artery, and that can be palpated in the groove between the trachea and that sternocleidomastoid muscle, medial to and alongside that, right? So when it comes to your carotid artery, you want to palpate for 30 seconds and multiply that by 2. Now listen to me. Somebody's going to do this in practice, and I don't want it to be you. You never want to palpate both carotid arteries at the same time. You can actually cause a vasovagal response, and you are limiting that blood flow from getting to the brain. So you're only going to do one side or the other. You never want to do them at the same time. Next, we have our apical pulse that's auscultated at the left midclavicular fifth intercostal space. And the apical pulse needs to be counted for a full minute. And it is assessed in patients with irregular radial pulses or a heart condition and between administration of cardiac medications such as digoxin as well as beta blockers. Next, you have your brachial artery, which is what we listen to when we're looking for blood pressure. And that's right above the elbow at the antecubital fossa, which is right in here, between the biceps and triceps muscles. Next we got our radial artery. That's palpated in the groove alongside the radial and thumb side of the patient's wrist. With this one, you're going to count for 30 seconds and multiply that by 2. Next, we have our femoral artery that's palpated between the inguinal ligament, midway between the symphysis pubis. So for those of you going into the cardiac fields, this is traditionally where they put the sheaths when they're doing different kinds of interventions. And if you were to remove it, this is what you're going to be pushing on until it clots. Next, we have our popliteal artery that is palpated behind our knee. Our posterior tibial artery, which is palpated on the inner side of the ankle, behind and below that medial ankle bone. And then lastly, we have our dorsalis pedis artery, which is palpated on top of the foot between the great and first toes. So as we're palpating, we are also grading our pulse rate. So a 4+ is known as a strong and bounding pulse. A 3+ means that we have a full pulse that's increased. A 2+ means that it's normal and it's easily palpable. A 1+ means that it's weak and it's barely palpable. So sometimes with our Dopplers where we're trying to find the pulse, this could potentially be a 1+. And then 0 means that we have absolutely no pulse present and it is not palpable. So next, let's start considering some nursing considerations when it comes to pulse rate. So what are some potential causes when we have slower pulse rates, also known as bradycardias? So the heart rate slows down with age. That could definitely be a possibility. There's also the possibility that the patient is a well-conditioned adult. Like we talked about before with our athletes, they are known to have slower pulse rates. Depressant medications such as benzodiazepines can absolutely have a role when it comes to slowing down the pulse rate. Now, what are some potential causes when it comes to faster pulse rates, also known as tachycardias? Well, exercise can absolutely increase your heart rate. Emotions stimulate that sympathetic nervous system that we talked about before, causing an increase in heart rate. Pain can also increase the heart rate, not always accurate when it comes to our chronic pain patients because they tend to become accustomed to the pain, so they no longer show those other symptoms when it comes to pain. Increased body temperature can cause an increase in the heart rate. Stimulant medications such as Adderall for ADH can increase it. Low blood pressure can cause the heart rate to increase. As we talked about in another video, I highly recommend you check out. When it comes to compensatory mechanisms inside our body, if the blood pressure goes low, then the heart is going to go up in its rate because it's trying to push all of that circulating blood volume even though there's this low blood pressure. So that absolutely can cause the heart rate to go up. And then lastly, hemorrhage can cause the heart rate to increase because as we're losing fluid or as we're losing blood, in the case of hemorrhage, the body is going to try to compensate for that by increasing the heart rate to push that readily available oxygen to the tissues before eventually you just don't have any blood and then there's nothing left to pulse. And then lastly, let's start talking about some critical thinking when it comes to the pulse rate. So not every patient is going to have a normal 60 to 100 heart rate, right? So it's really important that we follow trends. So if the patient's heart rate is normally 60, and now the heart rate is 90, it's not considered a tachycardia yet, but it is tachycardia for the patient. So that's why it's so important that you follow the trends to try to catch potential problems faster before we now have a heart rate in the 120s when their normal is 60. We've now doubled their heart rate. And lastly, pulse deficit. So that's defined as the peripheral pulse, such as like the radial pulse, is less than the ventricular contraction rate, such as the apical pulse. So really this indicates that there's a lack of peripheral perfusion, potentially due to a cardiac dysrhythmia. So cardiac contractions are ineffective and it's failing to send that pulse wave to the periphery. So when you have a peripheral pulse rate, like a radial pulse, that's less than that ventricular contraction rate, which is your apical pulse, absolutely there's some kind of peripheral perfusion that's not taking place. So it's really important that you look at these two pulse rates together to make sure that they're equal to catch a potential problem that could inevitably manifest into something else. I hope that these videos were helpful in understanding vital signs assessments. Make sure you check me out on my social media. I'm on Facebook and Instagram, and if you haven't done so already, make sure you subscribe here on YouTube and turn on that bell notification so that way you're notified every time I post a new video. Go over to my website at www.nursecheung.com where there'll be additional resources based on these vital sign videos. But until next time, I hope you're having a wonderful day and I will see you all again soon. Bye.